Hello, everyone. Welcome to this evening's live broadcast, Road to Normal, COVID-19's Impact on Infection Prevention. I'm Allie Ward, Editorial Director of Infection Control Today, and I'll be your moderator for tonight's event. We are pleased to bring you this live webcast hosted by Infection Control Today and sponsored by Metrics. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions at the end during the Q&A portion of the event. You can submit questions throughout the presentation by typing them into the Q&A box, which can be found in the menu along the bottom of your screen. We will try to get to as many of your questions as we can. The slides will advance automatically during the event. If you have any technical problems viewing or hearing this presentation, please click on the question mark Help widget in the dock at the bottom of your presentation window. I would also like to mention that as part of our commitment to providing education to healthcare and industry sciences professionals during the COVID-19 pandemic, attendance at this webinar is free of charge. However, if you'd like to make a donation to help first responders through the New Jersey Pandemic Relief Fund, Infection Control Today's parent company, MJH Life Sciences, will match all contributions. To make a donation, please click Donate below and complete the requested information. I would now like to introduce tonight's featured speaker. This evening, we are joined by Sharon Ward-Fore, an infection preventionist from Chicago, Illinois. Ms. Ward-Fore has a background in microbiology, which gives her an especially unique perspective when it comes to the spread of infectious pathogens. She has expertise in PPE selection, training, donning and doffing, hand hygiene, cleaners, and disinfectants. Tonight, she'll be discussing the road to a new normal and how the COVID-19 pandemic will affect the future of infection prevention. Ms. Ward-Fore, thank you for joining us today, and please feel free to get us started.
Okay, thank you, Allie, and hello, and thank you to everyone for taking the time to view this webinar. I hope to provide some guidance and resources as we look to slowly and safely reopen healthcare in the United States. So as you all know, COVID-19 was declared a pandemic on January 31st, 2020. As the virus began to spread and overwhelm our healthcare system, a recommendation was made in March by the Centers for Medicare and Medicaid. And they recommended that we limit non-essential patient care in an effort to preserve resources. And those resources were really caregivers, supplies, equipment, beds, and everything associated with providing care to patients during this pandemic. And the limiting of non-essential patient care was to allow for additional capacity to care for COVID-19 patients. As this pandemic continues, CMS has recognized that many states and localities now have low and stabilized incidence of COVID-19, which is providing an opportunity to slowly and carefully restart care to non-COVID patients that may have had their care postponed, such as surgeries and procedures, chronic disease care, and preventative care. The restarting of non-COVID care is part of phase 1 of the guidelines for opening up America again. And that was proposed by the White House Coronavirus Task Force. Please keep in mind, and this is really important, this is not a flip the switch reopening. Every state will have to assess their own situation to determine if and how to move forward, collaborating with state and local health departments and public officials. Specific gating criteria regarding symptoms, cases in hospital needs to be met prior to entering phase 1, the reopening phase. The CMS guidelines provide a gradual process for restarting non-COVID essential care while keeping patients and staff safe. So let's look at the general considerations at reopening. CMS says that everyone needs to maximize use of all telehealth modalities whenever possible. We need to screen patients prior to allowing entry to our facilities, no matter what that facility is. We need to evaluate the necessity of care based on clinical needs. Do these patients really need to come in at this point in time, or can we hold off further with some elements of care? We're going to need to prioritize procedural care and high complexity chronic disease management. Again, figure out which is really life-threatening or life-changing and manage some way to get those patients in safely. For facilities that are large, you're going to need to establish a non-COVID care or COVID care zone. And those would be in hospital settings or other facilities that take both kinds of patients. And you're going to have to require your non-COVID care patients and staff to have screening, including temperature checks. So let's look at some of the things we need to consider. CMS says there's a few key healthcare considerations when you want to open during a pandemic. And this pandemic is still ongoing. Things to consider would be workforce availability, facility considerations, testing capacity, personal protective equipment, infection prevention protocols, and regional considerations. And we're going to talk about each of these in greater detail. So CMS recommends that you look at your patient screening process and that you identify sufficient healthcare to conduct telephone, text monitoring, or telehealth interactions with patients before the visit. So they're saying you need to try to identify staff that are knowledgeable and comfortable screening patients, whether by phone or computer. Throughout this rapidly evolving pandemic, the importance of patient screening has come to the forefront. Infection preventionists have known the importance of patient screening for quite a long time. As an IP that covered the ED, basic everyday patient screening at triage was very, very important. Travel questions were asked when diseases were circulating like pertussis or measles. More screening questions were developed to help identify Candida auris from patient transfer locations like skilled nursing facilities and long-term care. So really, patient screening to a certain degree has been in use for a while. Think about surgical centers. People there give preoperative calls to patients prior to a scheduled procedure. Your primary care facilities. Think of the patients you call to give an appointment reminder, or think of the patients that call in to schedule a visit. These are opportunities to ask health-related questions. Now, screening programs become even more vitally important. A robust screening program now and into the future can help safely prepare your staff for that next patient that arrives at your facility. And I can tell you the screening at triage was a way to kind of circumvent or mitigate patients that came in with communicable diseases. So seriously consider how you can get a program started in your facility. Another big push is for telemedicine. And telemedicine has actually been in use for some time. And right now it's rapidly and successfully expanding into other areas. Embrace this technology now. And if it's appropriate for your facility and scope of practice, keep it and continue to use it even as we roll through this pandemic and go on to whatever the next big thing is. CMS says you need to develop these protocols so that healthcare triage and assessment of patients can happen prior to entering or immediately upon entering. So every facility is a little different. Primary care may be different from an urgent care, which is different from a surgical center. So develop your protocols based on answers to screening questions that are relevant to your practice. This can help with decisions on how to safely let a patient into your facility. When I was an IP, I worked in the emergency department, and I developed this thing I called the respiratory hygiene algorithm for the ED staff. And it was simply a list of communicable diseases like mumps, measles, pertussis, what the action should be, and they all really were masking, and then what the staff needed to do after that, whether patients needed to go into negative airflow rooms, whether they needed to be on droplet precautions, just kind of how to handle the patient. And it was just a way to simplify how patients move through triage. It provided a quick guidance on symptoms, presentation, masking, and need for additional precautions. So think about how you might be able to develop your protocol and make it simple. Algorithms seem to work for just about everybody. It's a great visual tool that most people can understand very easily. So let's look at some of these screening questions that are provided by the CDC phone advice line tool. And these are specific for COVID-19, but you can tweak these for whatever you need for your facility. Things to ask are you ill or calling for someone who's ill? In the past 2 weeks, have you felt sick? Have you come in contact with someone who's been diagnosed with COVID-19? Or do you live in or visit a place where COVID-19 is spreading? Do you have any of the following symptoms? And they list all the current symptoms for COVID-19. So these are really relevant questions for this point in time as you reopen, because COVID-19 is still out there. And we need to be aware of that and make sure that we're asking the questions so that we know what to expect from patients that either call to schedule an appointment or patients that are coming through our doors without a scheduled appointment. Visitors should also be prohibited from coming into your patient screening areas. If that visitor needs to be there to help that patient, then make sure that you pre-screen the visitors. So a question to ask is, will you be coming with someone else? And then you're going to need to ask the same questions of them. Again, because COVID-19 is circulating in our environment right now. So one of the other things we need to look at are really patient waiting rooms. Now, I'd like you all to close your eyes and visualize what some of your waiting rooms look like. When I close my eyes, I see a waiting room where patients are sitting shoulder to shoulder and back to back. Even in the best of times, this really is not a good setup. Think about the cold and flu season. People are right next to each other, spreading and shedding. And this is especially bad during a pandemic. So we need to think about ways to reduce crowding in waiting rooms. There's some creative solutions out there. CMS has been pretty good with providing information about it. They say maybe stagger your appointment times or reduce your hours, and maybe just in the beginning till you see what's happening in your locality. You might consider asking patients to be seen, that they're waiting to be seen, to wait outside in their car and wait until they're called into the facility for their appointment. And when I think about this, I think about those little things that restaurants give you, that the lights flash when your table is ready. So there's technology out there that we maybe want to consider using. You can also set up triage booths to screen patients safely outside of your facility. So these are all creative solutions to figure out how to reduce crowding in your waiting room. Another thing they say is to ensure face masks are available at triage for patients with respiratory symptoms. And they clearly say face masks. Now, if there's a shortage of face masks and if a patient has called ahead of time, be sure to tell that patient to wear a face mask into your facility. And right now we're saying we can use cloth masks as a form of universal source control, and that's for patients, but not for staff. And for staff that are in those front-facing positions, don't forget eye protection. Mucous membranes are also, eyes are also included as part of mucous membranes. So it's not just your nose and your mouth you need to protect, it's also your eyes. So when your patients are entering in your areas, and say you're a facility that has COVID care and non-COVID care, so you're going to have to be creative in a way to physically separate patients with respiratory symptoms. Ideally, we still want to have social distancing at least 6 feet apart in waiting areas. And if your facility lacks a waiting area, then you're going to have to figure out a way to designate a waiting area or figure out a way to partition your waiting lines. Now, social distancing needs to continue. It's a proven strategy to prevent transmissions. Areas that lack barriers in your waiting areas, IP, you'll know the answer to this. Bring in your construction barriers, your edge guard and your visqueen if possible. They aren't pretty, but they get the job done. And you can also add HEPA filtration if you need to. And if you don't have those things at the ready, consider simple plexiglass partitions. You can put those at registration desks to keep your staff safe. You can position those throughout your facility. So be a little creative when you look at your space. You should also consider printing and placing signage throughout your facility to remind patients about the social distancing standards, respiratory hygiene and cough etiquette, and hand hygiene. They say you should place visual alerts such as signs and posters actually all over the place so that nothing is missed. And these would be things on hand hygiene, again, respiratory hygiene and cough etiquette. And the CDC has a lot of great resources that you can simply download and print. You need to ensure that supplies are available in your waiting areas, such as tissues, which are actually considered a form of source control, hand soap, wash receptacles, and alcohol-based hand sanitizer in areas that are really easy to get to for your patients. Another thing you're going to need to do is remove magazines, reading materials, toys, and other objects that can't be disinfected after they've been touched by patients. And lastly, don't forget to increase cleaning and disinfection in all of your waiting areas. We know droplets can live on plastic and steel for up to 3 days, so extra cleaning in these areas adds an additional level of safety for all. So workforce availability is one of the other areas CMS says we need to consider. All staff should wear a face mask. And remember, cloth masks really aren't considered PPE. But if push comes to shove and that's all you have, then that's what you need to use. So remember, some kind of facial covering for your staff as well as eye protection. Staff need to be screened for symptoms of COVID-19 at the beginning of each shift. This is a good way to keep an eye on what's happening with your staff. Try to make this as easy as possible. There's a lot of technology out there right now that allows for self-screening. There's kind of like a tap and go badge thing where you can answer a bunch of questions electronically. There's also thermal thermometers. And if you don't have the money or the resources for that, maybe you have the manpower to position someone at your door who could simply ask some questions and take someone's temperature. And also offer staff face masks if they don't already have them. So for those that are symptomatic, they should be tested and quarantined. And as soon as you know you have a symptomatic healthcare worker, make sure their face is covered, inform their supervisor, and have them leave the workplace. Critically important. Now, the CDC has a lot of guidance around this, and there's the interim guidance for risk assessment and public health management of healthcare personnel with potential exposure in a healthcare setting to patients with coronavirus, COVID-19. It's a mouthful, but it's a really great resource that will help you figure out what to do with your staff and how to conduct a risk assessment to find out the different ways that you can manage your staff through a positive or a potential exposure. Another thing that's really important is staff should not rotate from COVID-19 care zones or hospitals to non-COVID zones or facilities. We really would like to keep separation as much as possible. Staff that care for COVID patients should not go anywhere near the non-COVID zones. CMS is quite adamant about that. Another thing to look at is your staffing levels. So we know that the COVID-19 is currently still circulating in our community. Right now, most places are at a level where they can sort of contain it and have enough staffing coverage to adequately care for patients. But keep your eyes on this and make sure that you have enough staff in case there's a potential surge and you need to shut down your non-essential care and now provide COVID-19 care. And then the other thing is your sick leave policies should be non-punitive, flexible, and consistent with public health guidelines. And another good resource for how to answer staffing questions can be found on the CDC website, Strategies to Mitigate Healthcare Staffing Shortages and Return to Work Criteria. Lots of great tools and checklists to kind of help you maneuver through this quagmire of so many different questions with so many different answers. So in order to reduce the risk of exposure or transmissions, we're going to have to consider our facilities themselves. And again, I can't stress strongly enough how important it is that non-COVID care facilities or non-COVID care areas be separated to the highest degree from each other. Separate buildings, separate areas of the buildings, even a separate entrance with minimal crossover is recommended. They even go so far as to say separate parking areas and separate walkways. So if you're able to separate to this degree, that would be amazing. We'll see how it goes for a lot of facilities. And also within your facility, there's engineering controls that could help facilitate the social distancing. And we talked about in the waiting areas where you could space chairs 6 feet apart, but you also want to minimize your time spent in your waiting areas, and that's in all waiting areas and even in recovery areas. You want to maintain low patient volumes in all of these areas. Another thing is maybe you can consider installing more physical barriers. And then another consideration might be to see if you can increase your air exchanges per hour in these areas. And that will help the air move through the facility faster, cleaning out any particles that may be present. So testing capacity. All staff and patients must be screened for potential symptoms of COVID-19 prior to coming to a non-COVID care facility. And that's what you all are. You're providing non-essential care to non-COVID care patients. But you don't know if they're a non-COVID care patient until you screen them for symptoms. So at the very least, you have to ask the questions that we talked about in the very first couple of slides. Your staff should also be screened routinely for potential symptoms. And then when adequate testing levels are established, you should you should test all patients and staff. Because why do we want to test? Because we want to determine exactly what is going on with our staff and our population. And the testing of staff and patients should be performed regularly. The reason is, after a virtual screening is done for symptoms, then we really get down into the nitty-gritty of it and actually determine how many asymptomatic carriers we have. And we know this virus has been detected in 18 to 25% of asymptomatic carriers. And the symptoms can appear between 2 and 14 days after exposure. So this is a pretty huge window for someone to be in your facility as a patient or a staff member and not know that they're actually carrying COVID-19. We can only hope for more rapid testing, the kind of testing that happens within minutes, and let's hope that becomes more widely available. And another reason we should test is because testing will also help with the epidemiology of COVID-19 by providing data to help assess the COVID-19 levels in your area. Remember, this is sort of uncharted territory, and we need to gather as much data as we can about testing. So seriously consider it for your facilities. Personal protective equipment. This is my baby. So everyone needs to assess their inventory of PPE. And what you need to do is figure out a frequency of looking at your inventory that let you stay on top of your PPE supply. You may not burn through, gowns as often as you're going to burn through face shields or N95s, but figure out what that frequency is and be sure someone is eyeballing your PPE supplies. Now, if you're fortunate enough to have enough PPE, you're going to need to follow your standard infection prevention protocols. But again, be sure to have enough supplies on hand should a second wave of COVID patients present to your facilities. So we also need to define appropriate PPE items needed based on the precaution level required. So the CDC recommended PPE for COVID-19 patients is very clear. Gowns, gloves, a respirator, either an N95 or a PAPR, a face shield or eye protection where it's available. If N95s for routine care of COVID patients are in short supply, they say you can use face masks or procedure masks, but this does increase staff risk. And the intent here is really to reserve your N95s for use during aerosol generating procedures. And just make sure you know what aerosol generating procedures are. The CDC gives a list of aerosol generating procedures. They're open suction airways, sputum induction, endotracheal intubation and extubation, non-invasive ventilation like BiPAP and CPAP, bronchoscopy, and manual ventilation. But also consider nebulizer treatments and high-flow O2 delivery. The jury is still out on whether aerosols generated by these procedures pose a risk, according to the CDC. So remember, for all of these types of procedures, you really need to wear an N95 to keep yourself safe. So which of these procedures does your facility perform? Do you know? You're going to need to find out in order to have enough N95s on hand. If you don't have enough N95s on hand to perform these aerosol generating procedures safely, you really should consider postponing these procedures until you have the proper PPE. Surgical centers, you're going to have different needs than outpatient, inpatient, and primary care settings. This is not a one-size-fits-all kind of mandate. You need to look at your procedures, figure out the number you do, and what kinds of PPE are recommended, and what do you have on hand. So here's a really scary new reality for IPs and staff. Routine use of PPE for isolation precautions may not be possible due to shortages. Yikes. So that accounted for a couple more gray hairs on my head. But there's a way around this. Facilities experiencing PPE shortages, especially inpatient settings, should look to the CDC for guidance. And they have a whole bunch of guidance called the CDC Summary for Healthcare Facilities, Strategies for Optimizing, and there's one for gowns, there's one for gloves, there's one for masks, and there's one for respirators during the COVID-19 response. Now, to parse it down into something that's understandable, what they're saying is consider not using gowns for patients with endemic MRSA, VRE, and ESBLs, except as required for standard precautions, where you're going to anticipate a splash or a spill or something like that. But always wear gloves for contact with the patients and their environment, and always perform hand hygiene. So this is a little different from our normal contact precautions for these kinds of organisms. They also say that patients who have highly resistant gram-negatives like CREs and other MDROs like Candida auris that are not considered endemic don't wear gowns upon every entry. That was also an addition of a few more gray hairs. But they have a way to deal with it. They're suggesting you use a bundled approach to going in and caring for these patients. Reserve your gowns for use as part of standard precautions, but also bundle in prioritized high contact patient care activities that pose the highest risk to your staff, such as bathing, turning, device care, and linens. So really, bundle your activities, go in there one time, get all that stuff done, wearing your gown, your glove, and perform your hand hygiene. But if you're just going into the room to talk to the patient, they say you don't need to wear gowns. You do need to wear gloves and always perform hand hygiene. And for C. diff, they say a gown and glove every time for the known positives, but they're also recommending that you suspend the use of gowns and gowns for the rule-out patients. So for IPs, this is a little different from what we're used to. It's a little tricky, but we will figure it out and make it work. The other thing we should talk about is healthcare providers should always wear a surgical mask at all time. Again, I will remind you that a cloth mask is not considered PPE, but if that's all you have, it's better than nothing if it's wet, because then it begins to lose its whatever filtering ability it had. Patients should wear cloth face masks if they do not already possess surgical masks, and you need to practice proper donning and doffing techniques specific to the PPE in your facility. Now, you can go on all kinds of websites and see all kinds of YouTube videos of how to don and doff, but unless it's your specific PPE, I think it just causes confusion. So I cannot say enough about how important hands-on donning and doffing, and I want to say upon hire and annually, of whatever your facility's everyday PPE is for all staff. I can't believe it takes a pandemic for us to realize how important our everyday PPE is. IPs, it's up to you to audit practices and give real-time feedback. This is really, really important. I have walked through our hospital, I can't tell you how many times, and seen people using PPE incorrectly. And when you stop and you carry on a conversation with them and ask them, what do you know, or how did you know how to do it this way? People usually say no one ever taught them. They sort of picked it up on the fly. So it's really important for IPs to get out there, audit the practices, give real-time feedback, and train people. Train them how to take it off safely. And now, in this pandemic world, we have to train how to properly store and reuse PPE if it's in short supply. And this becomes extraordinarily important. So remember, we need to get out there and help our fellow healthcare workers learn how to do the right thing consistently so they don't make themselves sick. And then CDC says to refer to their best practice for selection and sequence of PPE use. One thing I will say is try and simplify the doffing of your PPE. WHO has example 2, where you doff the gown and the gloves as kind of a one-piece set. And I found that up on the patient care units, this is really how they take them off. So kind of look at how your staff doff their PPE and train to the safest way to do that. If they're used to donning, or if they're used to doffing their gown and gloves as a one-piece set, that's what you should train to. If they're used to taking each piece off individually, then you should train to that too. So I have a question for all of you. So during this pandemic, we're reusing PPE and we're not using it like we used to use it. So when this ends, or however, whatever lies in the future, how do we justify the use of PPE when the pandemic is over for things like MRSA and VRE, when now we're saying it's okay to not use it? So here's what I'm going to ask all of you to do. I hope you're tracking transmissions and strain typing, because right now the cat is out of the bag, so to speak. And how do we go back to our normal standard infection prevention protocols without a lot of pushback? And I say the way we do that is we start collecting data now so that we have some information for what lies ahead. When everyone says, we didn't wear our PPE during the pandemic, why do we need to wear it now? So let's talk a bit about disinfectant selection for COVID-19. Now, we're all going to have to use disinfectants that are approved for COVID-19. That's pretty much mandated because right now, that's what we're up against, COVID-19. And the literature states between 18 and 24% of people can be asymptomatic carriers of COVID. And we know this virus can be transmitted through droplets and contact with those droplets. So selection and use of the appropriate COVID-19 disinfectant is really important. You're supposed to follow your routine cleaning and disinfection procedures that are appropriate for COVID-19 in healthcare settings. And those are usually, they actually are mandated to be EPA registered hospital grade disinfectants. CDC on their website says sometimes you can clean with soap and water and then use your disinfectant to disinfect if you're running low on disinfectants. What I will say is follow the routine cleaning and disinfection procedures that are appropriate to the hospital grade EPA registered disinfectant that you're using from List N. You should really pre-clean heavily soiled items, then disinfect them. The dwell time starts when the disinfectant is applied, and you need to follow the manufacturer's instructions for use. And I don't know how many of you have looked at List N, but List N can be sort of confusing. If your disinfectant has no emerging pathogens claims, or I'm sorry, I'm already confused. If your disinfectant has an emerging pathogen claim, then use that contact time. If it has no emerging pathogen claim, but a human coronavirus claim, you can use that contact time because the EPA currently considers anything that's effective against human coronavirus is effective against the SARS-CoV-2. So check out List N. If you have questions, you can actually email the EPA and they will help you figure out what to use. So surface disinfection. Surface disinfection is really, really important for the reasons we just talked about. We know that this organism that can be spread by contact with the droplets that are on surfaces. So you should understand your whatever surface disinfectant you select. You should understand the product instructions for use. Be sure you know how to use your List N disinfectant. Train whoever is cleaning on how to use it. And now one caveat is that CDC recommends only essential personnel enter COVID rooms. So in some cases, staff, other than your usual environmental services folks, may be performing cleaning. It could be nurses, it could be EDAs, it could be aides. So make sure anyone who's going to be responsible for cleaning is trained up on how to use that particular disinfectant. Clean before disinfection. I can't tell you enough how important this is. And the reason being, if there is bioburden on a particular item, a medical device or a patient tray in their room, unless you remove that bioburden, the disinfectant is not able to touch those surfaces. So it's really, really important to clean before disinfection. Okay, so also remember to complete the required contact time for that disinfection. Every product lists its contact or dwell time. that clock starts ticking if you're pre-cleaning. Once you've cleaned that item and you apply that disinfectant, that's when the clock starts ticking. Fortunately, most disinfectants seem to have a lot of product in them, and they will actually stay wet. Hopefully, if it's not a dry one that you pulled out of that tub, they'll stay wet for the disinfection time and maybe even a little longer. It's really important to communicate facility protocol to the entire staff. Train and audit on the process and the chemicals regularly. Practices drift. Staff may be in a hurry. And sometimes staff think more is better. And I actually saw this at my former institution where the staff thought if you use 3 squirts, then 10 squirts is better. So be sure that you're monitoring this regularly and train, and audit to make sure everyone's following the same protocol. It's really important to identify the cleaning owners. Identify who cleans what equipment. This is a process that seems to break down fairly regularly. When I covered surgical services, this happened fairly often. People would point the finger at each other and say, oh, well, anesthesia cleans this, but EVS cleans that. So what really needs to happen is everyone needs to collaborate and figure out who cleans what, make sure everyone is trained on who cleans what, and audit a lot. And this will help keep your practices from drifting. And don't forget to specify the cleaning frequency. For things like waiting rooms or areas where patients tend to congregate or stay for a long time, you may want to increase the frequency of your cleaning, because increasing frequency, what does it do? It decreases the bioburden buildup on the items in that room. And here's a little tidbit I learned from CDC as I was preparing for this presentation. CDC states that upon discharge of a COVID positive patient, the room should sit idle for a time frame based on number of air exchanges per hour. Now, a regular hospital room has about 6 air exchanges per hour. So that room would have to sit idle for 69 minutes prior to entering. And anyone who enters still has to wear all the appropriate COVID PPE. Now, you have to think about how you can operationalize this, and I wonder if this is even possible. So just a little FYI out there, things to consider. And don't forget, we need to determine our cleaning order, and we'll talk about that in a minute. So my little infographics here show you different areas, different patient rooms, exam rooms, waiting rooms, and you can see they're all a little different. And the main thing is make sure there's a plan to thoroughly clean and disinfect all the patient care items that are touched and used. Figure out the frequently touched surfaces in your particular facility. Exam rooms are different from public waiting rooms, and not all waiting room or exam rooms are the same. What you really need to do also is try and limit the amount of supplies and equipment in the room to make it easier to clean. Keep your supplies stored in cabinets or drawers. That's actually why they're there. And be sure you can close them. There's no need for 7 days worth of linen or enough IV bags on the counter for an entire week's worth of surgeries. IPs, does this sound familiar? Probably. So pre-pandemic, we should have been stocking rooms leaner. Now, during this pandemic, and maybe moving forward, it's really important to pare down the supplies left in the room to prevent transmissions and to make cleaning easier for everyone. Let's do this now and stay with it even after the pandemic has moved on. So this is the recommended cleaning order. You clean from top to bottom, clean to dirty, clockwise or counterclockwise. When I look at this slide, the one thing I want to ask myself is, does all of this stuff need to be in the room? So think about paring down what's actually in the patient room too, to make it much easier to clean. The cleaning order hasn't changed, but what we need to think about is whether all this equipment is necessary. And the clockwise or counterclockwise, whatever you decide, make sure everyone is following the same order and audit this practice. When I was auditing our EVS workers, I can tell you clockwise, counterclockwise, everybody was doing a different dance in the room. So make sure you're all on the same page with which way it goes. You'll do better in a Joint Commission audit if everyone's following the protocol. So the importance of hand hygiene hasn't changed. It's always been the first line of defense against transmissions. And when we look at these bullet points, we see communicate hand hygiene guidelines to the entire staff, talk about the different techniques, talk about those 5 moments for hand hygiene, and emphasize why compliance and visible demonstration is really, really important. You want to hand wash with soap and water when your hands are visibly soiled, and you can use the alcohol-based hand rubs when they aren't. And the hand sanitizers for COVID-19 should be greater than 60% alcohol. That's what CDC has recommended. And that's if hands are not visibly soiled or dirty. And as we move through this pandemic, we're finding more and more people are doing hand washing with soap and water. So let's talk more about hand hygiene. And I mean the real meticulous, not the pump and run hand hygiene, but hand hygiene performed correctly. Now, this is an infographic from the World Health Organization. There's 11 steps to clean your hands with soap and water, and there's 8 steps with alcohol-based hand rubs. It's pretty thorough. But I want to talk about how important that thoroughness is. As an IP, I had the privilege of training staff on the Special Pathogens Ebola response team. And we talked about hand hygiene you do every day and the way hand hygiene should be performed. And we call the hand hygiene that should be performed correctly the hand hygiene that could save your life. And this WHO diagram demonstrates how hand hygiene should be performed every time. The application of soap and water or the alcohol-based hand rub to every hand surface. It's almost like performing a surgical scrub. When it's performed this way, meticulous and thoughtful, it can really make a difference in staff and patient safety. The challenge now, as it has been in the past, is how do we build in the time to get it performed like this for every patient encounter? If any of you figure that out, please let me know. So we're going to talk a little about regional considerations. As states and localities begin to open up, they have to do it in a slow, phased-in method, adhering to the gating criteria and the guidelines in the Opening Up America Again steps. Remember that this should be a baby step approach to opening up based on meeting your local and state criteria. Unfortunately, comprehensive testing and systematic contact tracing are sorely needed to open up safely. Most states at this point in time don't have the resources for either of these. It's really important now that you partner with your local health department. They're a great resource to help keep you involved in what's going on in your community. And keep tapped into what is happening in your area and your facility. And look to your health department and also look to the CDC for guidance. They've been really great throughout all of this with a lot of information, almost too much information. Now, there's one thing I wanted to share with you, and it's this cool little how is my state doing with COVID-19 kind of thing. It's at covidactnow.org. We've provided a link to it at the end of the presentation. And I'm in Illinois, so I clicked on Illinois, and this is what it showed me. And it showed my infection growth rate. It's very simple. Unlike the data-heavy Stanford University or Harvard models, this spells out very simply what is happening in my state of Illinois. And this is a shot of what Illinois looked like yesterday. So when we look at our infection growth rate, ours is at 1.10. And the recommended infection growth rate for reopening is 1.0 for 2 weeks prior to opening. So we are not there yet in Illinois. The positive test rate, WHO recommends the positive test rate be less than 10% before reopening. And they also say that the most successful countries containing COVID had a rate less than 3%. So you can see in Illinois, we should not be reopening based on this test rate. Then it also shows the ICU headroom, and there is no benchmark for this, but it kind of shows you where you are with your ICU beds and gives you an idea of what would happen if there were a surge. Now, there's a predicted outcome section by August 8th, 2020, 90 days from now. And Illinois has been pretty good with hammering home the stay-at-home order and the masking in public and the social distancing. But if we were to lift all our restrictions, by June 1st, our hospitals would be overloaded with greater than 70% of our population infected and 67,000 additional deaths. If we keep going the way we are, stay-at-home orders, masking, social distance, in the next 90 days, our hospitals should be fine. Our population infected will only be about 33%, and it'll be fewer deaths. So if you get a chance, I recommend you play around with this. It's kind of a cool thing, and it gives you a lot of easily understandable information. So we're going to kind of wrap this up. Much is still unknown about COVID-19. Every day we are bombarded with more information about the virus, and some seems contradictory to what we knew just yesterday. This is an evolving story. We have not tamed it or defeated it. Will the end of it come from simply winding itself down? Or will society say, we've had enough isolation, just let me out? Care for non-COVID-19's must continue to safely expand. And by following the recommendations, however this ends, we know that deferred care cannot stay deferred forever. We have to begin to slowly and safely open up care in areas where it is safe to do so. And opening up is really uncharted territory. And we can see now what is happening in other countries that have opened up. They're starting to see an uptick in infections. So we know by opening up, there are risks involved. As IPs, we have a lot of tools at our disposal that we've used for past outbreaks in our facilities. We cohort, we perform surveillance cultures, we track transmissions, we strain type, we audit hand hygiene, PPE in our cleaning processes. We perform real-time training and coaching. With these tools, we can help monitor what's happening in our facility to safely reopen services and monitor for upticks in infections. I ask you to be vigilant and be flexible. And if you see an increase in infection in your area, please reevaluate being open. Prepare for the second wave of COVID infections by maintaining facility flexibility. We know a second wave is coming. We don't know when or how bad it might be, so be prepared. Prepare by assessing your medical supplies, your equipment, and your PPE frequently. And don't forget your staff. Make sure your staff is doing okay. Recognize the toll this prolonged, heightened awareness may take on staff physically and emotionally. The staff worldwide have been troopers, but how long can they maintain that? So be cognizant of that. Let each other know that you have each other's backs and that you're there for each other. And remember that staff fatigue can lead to lapses in infection prevention protocols. So you're going to need to monitor your staff, provide positive feedback and real-time coaching, probably more than you ever did before, especially with reusing PPE if you have to do that. You should provide continuous communication. Your facility should provide continuous communication and transparency about how you're doing overall. And your facility needs to let the staff know where you are as far as COVID patients in your area. Keep everyone informed so no one's guessing and no rumors start floating about what's going on. And make a commitment to have a preparedness plan in place and train on this regularly. And don't just do tabletop exercises. Get in there and do a real deal training. Remember, these are uncharted waters for a lot of things, but infection prevention basically remains the same. The same tools will work: surveillance, rounding, auditing, tracking, tracing, teaching, coaching, being the calming voice when chaos reigns. Be watchful of what is happening locally and elsewhere. Maintain this heightened sense of awareness through vigilance. The pandemic is ongoing, and now we are adding more patients, staff, and supply usage to the mix. We don't know what the next big thing is, only that it will come, so be prepared. Thank you, frontline workers. Everyone be safe out there. Allie?
Yeah, thank you, Sharon. Thank you so much for that informative presentation. We are ready to jump into your questions. So before we get started, I just want to remind our audience how to submit. You can submit questions by typing them in the Q&A box, which can be found on the right-hand side of the presentation window. All right. Our first question is, when it comes time to reopen my primary care office, what is the most important precaution to have in place?
So I would say the most, should I answer that?
Yeah.
Sorry, I can't see anything. Okay, so I think the most important thing would be to have that screening process in place. For primary care, it's when that patient is calling in to schedule an appointment, or if someone is walking into your facility. Screening is going to be ultimately important. It's your first line of defense. It will let you know who is walking into your facility well ahead of time, so you can be prepared with PPE and whatever else you may need.
Our next question is, why is it so important to reopen now when COVID is still happening all over the world?
Well, it's important to open now because a lot of people have deferred their care, and it was really only deferred because we didn't want to use those resources. And there are people out there who are still suffering with maybe things that wouldn't be considered life-threatening, but still quality of life type issues that need to be addressed. And if we can open safely and provide patient care that allows them to get on with their lives in an improved quality, I think it's something that we need to do.
We got this question a few times. You mentioned testing staff, but how often should they be tested?
At the beginning of every shift.
Okay.
Screening. Yeah, and testing, that's going to depend on the availability of testing. That would be different for every facility too. I know most places don't have the resources for it. I can't really speak to what that frequency would be because it's based on your local resources for testing. Sorry, it sounds like a cop-out, but every place will be different.
Right. Next question.
More is better.
Of course. Next question. You mentioned temperature screening patients when they enter a facility. What would you recommend as proper PPE for the staff who are performing the task of taking the temperature? Is it N95s, for surgical masks, face shields, gowns?
So your patients are supposed to be non-COVID patients. I would recommend whoever that staff member is, and depending on what they're using, I would definitely recommend eye protection, a face mask, and gloves. And beyond that, nothing else. If they're using a thermal scanner, there's almost no touching involved. If you're sticking a paper thermometer in someone's mouth, then you absolutely want to be wearing gloves. No need for N95s. We need to really reserve those for absolute positive patients and our aerosol generating procedures.
Right. You touched on surface disinfection in the waiting rooms. We have a question here on how do you clean fabric furniture?
So first of all, my IP hat comes on and it says, why do you have fabric in your waiting room? And if it's, plain old fabric, you might want to consider someday switching that out for a fabric that's absolutely cleanable. And there are a lot of, I want to say, Sumbrella type fabrics or fabrics that appear to be fabric, but they're really not. So they're waterproof and cleanable. So we know this is a fragile virus, and we know you can use soap and water to clean. And I will tell you that the CDC website actually has a snippet on how to clean fabrics. So I would go to their website to see what they recommend to clean. But again, they say soap and water is effective. And then because fabrics are porous. You will never get the padding inside clean, so you'll really only be doing surface cleaning. So in the long run, you might want to think about swapping that out for something that is not actually fabric and less porous.
Good point. Next question is, can you address infection prevention measures in dental facilities?
So yes, I do have a bit of knowledge on that. I do a little consulting for the dental industry, and I will tell you, the dental industry, the American Dental Association, has really stepped up and put out some amazing guidance. So I would direct you to their website. They've got a lot of stuff going on. They have algorithms for how to take care of patients. The one thing they really talk about, and I had to pull it up, was to use a rubber dam whenever possible to decrease possible exposure, and use high-speed evacuation for all procedures producing an aerosol. You want to minimize anything that produces an aerosol, and at this point in time, everybody in the dental world should be wearing a face shield. I know when I go get my teeth cleaned, that stuff is flying all over the place, and I look at my dentist, the hygienist, who's just wearing eye protection, and I can see that her eyes might be okay, but everywhere else has now got my goo on it. So face shields should be your friend in the dental industry. Oh, one other thing from the ADA website, and I thought this was pretty cool, is have your patient rinse with a 1.5% hydrogen peroxide solution prior to beginning any procedure. So that'll help clean out the mouth. It's probably very effective against COVID-19, but really go to the ADA website. It is amazing.
Yeah. Here's an interesting kind of case study question. If one of my staff members has COVID, when can I reopen his office after cleaning and disinfection? Do we have to close the whole building or only the office of the affected individual?
So is it his personal office? Is it an exam room? When they say his office, is it where he sits and does paperwork?
Unclear.
Okay, so what I will tell you about COVID-19. So we know we can live on cardboard for like 24 hours, which probably can translate to papers for 24 hours. I think we know it can live on plastic and stainless steel for 72 hours. So maybe the intent is to stay out of that room for a certain number of days and just let things die on their own, and then come in and clean with your regular cleaner on all those frequent touch surfaces. As far as air exchanges, we talked about a regular room has about 6 air exchanges. In 69 minutes, 99.9% of whatever is in the air would have been filtered through. So it's probably pretty safe to go in there after a couple of days.
We're running low on time, so we'll take a couple more questions before wrapping up. What are your thoughts on UVC disinfection systems to kill pathogens in entire whole rooms?
So I think UVC is really coming to light, no pun intended, but we can't forget the fact that even with UVC, you have to clean before you can get that disinfection by the UVC. So it might be great to clean a whole bunch of equipment and then push it in a room and throw the light in there and let it disinfect a lot of things. I think it's technology that's worth looking at, and there's all different kinds of applications for it. But remember, with anything like that, you still have to clean before you can disinfect, even with UVC, because you've got to be able to remove that bioburden so the UVC can penetrate.
We hear a lot about the possibility of a second wave of COVID later in the fall. What are your thoughts on that? Is it possible that that second wave could be much worse?
So no one really knows, but if you look at the 1918 pandemic with flu, the initial presentation of influenza was they kind of joked about it and called it the 3-day fever. And it didn't kill that many people, but it came back with a vengeance later on in the fall and killed 40 million people. So I think what we've learned from that is to take this seriously, because there's more we don't know about this virus than we do. And I would err on the side of caution. I'm all about social distancing and wearing face masks and just kind of like staying in the course till we learn more about this virus. I believe there will be a second wave, especially now that we're seeing more places opening up maybe sooner than they should. And we should be prepared for that. And if it doesn't happen, great. If it does, we're prepared.
Right. You touched a little bit on this in your presentation, but the pandemic has taken an enormous emotional toll on healthcare providers. Do you have any advice for IPs who are on the front lines?
So on the units that I covered, I wasn't just their IP, I was their friend. And I think it's really important for IPs that are out on your units, get to know the staff, because they're not just cogs in the wheel, they're people. And I can tell you on more occasions than I can count, I had people come up to me and they were able to unload. And it's not the role of an IP, but we're and not to be cliche, but we're all in this together. And if you just happen to be an ear that will listen so that someone can vent and then they feel a little lighter and can get on with their day, I think it's an important part of what we do. We're a resource, but we're part of their team, and teams help each other. So I think in this, we can do more than just talk about PPE. We can be there for them as an ear to listen.
Absolutely. I think that's a great note to end on. Unfortunately, we are out of time, but we will be sure to collect all of the questions that were submitted and answer them in a follow-up article on Infection Control Today's website. So I would like to thank the audience for attending and for participating in today's event. Thank you to Sharon Ward-Fore for sharing your insight. And I would also like to thank Infection Control Today and Metrex for making today's webcast possible. Be sure to follow along with us at infectioncontroltoday.com. And we'll see you next time. Goodbye.
Bye.